Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from UCB Pharma, Inc.
Hello, good evening, everybody. We'll give people a little time to settle down. And welcome to our program. So our program is Game Over, Stop the Ongoing Seizure. I'm Cheryl Hout. I work at Montefiore Einstein in the Bronx. And I'm going to introduce my colleagues. We've got Eric Pina Garza, who's professor of neurology in Nashville. We've got John Stern, who's professor of neurology in UCLA. And we've got Barry Goodall, professor of pharmacy in Madison, Wisconsin. So we are, we span the nation, and we hope that we're going to bring an interesting perspective to you tonight. And so we're going to start the game, start our program. The program tonight is going to have 3 rounds, and in each round, you'll be given the opportunity to answer questions, and the team that is the most accurate, the fastest, and answers the most questions is going to win satisfaction. But that's always fun. All right. So I'd like to introduce the evening by defining what we mean by seizure emergencies, because having a basis in that is important as we go through the rest of the program. What do you feel is the biggest barrier to treating seizure emergencies? Of time during office visit to discuss rescue medication, insufficient identification of patients at risk, lack of insurance coverage of rescue medications, incorrect administration of rescue medications, concern for respiratory depression, or lack of seizure recognition by family and providers. So throughout tonight, we hope that we will help you to elucidate many of these factors, so at least you can leave here for personally feeling more confident about choosing rescue medications and prescribing them correctly. So when we talk about seizure emergencies, there's a spectrum, and most seizures, what we're calling here a single acute seizure, that's most seizures. In studies, it's more than 90%. Most seizures terminate within 2 minutes. They are self-terminating. Not that there can't be injury and morbidity and mortality associated with them, but overall, these are the seizures we are less concerned about as compared to what we call seizure emergencies. And these seizure emergencies have, at this point, sort of fallen into 3 bins. We've got seizure cluster, sometimes called acute repetitive seizures or serial seizures. We've got prolonged seizures, and we've got status epilepticus. And in the next few slides, I'm going to talk to you about the definitions, and you'll see that even here, there's some lack of clarity. Seizure clusters. Overall, we view these as an abnormal increase in seizure frequency compared to the patient's usual seizure pattern. Now, unfortunately, and as I'm going to show you, there's no clear standardized or consensus definition. It's often described based on duration, seizure frequency, time between seizures, but these factors really vary across patients. So there is some lack of clarity in terms of defining seizure clusters, but I think overall, most of us in practice can hear a patient's description and recognize this is someone who fits this category of seizure clusters. Then we have prolonged seizures, and these are seizures where that have not terminated within 2 minutes, as we've said, and they yet have not progressed to status. And so we'll be talking more about those tonight. And then, of course, status epilepticus, which is a seizure with continuous clinical and/or electrographic activity, or, of course, recurrent seizures without return to baseline in between. And this is associated with high morbidity and mortality, and this is what we are absolutely trying to prevent. Which of the following does not meet the definition for status epilepticus? A, bilateral tonic-clonic seizure greater than 5 minutes. B, bilateral tonic-clonic seizure greater than 10 minutes. C, focal seizure with impaired awareness or impaired consciousness, now it's called, greater than 10 minutes. Or an absence seizure greater than 5 minutes. This question, as I'm going to explain shortly, does have a correct answer, absence seizure greater than 5 minutes. And so why are the other answers correct and not that one? Well, let's go to the definition of status epilepticus. And I think many of you, like myself, when we were training, we thought of status epilepticus as 30 minutes, right? That was the catchword. That's what we were all taught to believe. But about 10 years ago, the ILAE, following a task force that worked on the terminology and classification, proposed a revised definition that much more matches what we're finding in clinical practice and what is important operationally. So while this is called a conceptual definition, it's a very interesting approach. We've got a T1 operational definition and a T2. T1 is when a seizure is likely to be prolonged, leading to continuous seizure activity. So that once you hit that point, you start to believe this seizure is not going to self-terminate. And T2 is when a seizure may cause long-term consequences, including neuronal injury, neuronal death, alteration of neuronal networks, and functional deficits. And those of you who heard the presidential symposium this morning, we heard a lot about potential long-term effects and effects on the developing brain of seizures, and particularly status. So we very much have moved towards wanting to stop seizures in that T1 phase before you get to T2. And as you see, different seizure types have different proposed definitions. So a tonic-clonic status epilepticus, you hit T1 at 5 minutes. And so that's when, once you get to that, you need to be very concerned that this seizure is going to continue on and become status. For a focal seizure with impaired awareness, impaired consciousness, the number is 10 minutes, whereas we used to think of that as more than 60 minutes for status. And for absence status, the number is 10 to 15 minutes, which is why that prior question we said was incorrect. Then we get to prolonged seizures. So prolonged seizures sort of fit in between the duration of a typical seizure and status. And again, we have a proposal that actually Eric here and some colleagues wrote up very beautifully last year, a proposal to define prolonged seizures, again, based on the seizure type. So a bilateral tonic-clonic, we've got between 2 minutes and 5 minutes, a focal between 5 and 10 minutes, and a generalized absence between more than 2 minutes is prolonged, and then of course later than that you get to status. The hardest one is seizure clusters. This has been all over the map, and I'm not going to obviously read all of these, but if you see this first definition, this is what was used in the original rectal diazepam study in the US, so the first of the rescue medications. And that was defined as multiple complex or generalized seizures occurring within 24 hours, or for adults, 12 for children, with a pattern distinguishable from the patient's usual seizure pattern and onset readily recognizable by a caregiver. Very complicated. They did the study. We all know it was, the drug was approved, so obviously the caregivers were able to identify these. But you see in other studies, including the studies related to the two more recently approved rescue medications, the definition is very variable. And you've got numbers of seizures, for example, 3 seizures within 24 hours, within 4 hours, 2 seizures from midnight to midnight. It's very confusing. And the field does need to converge on a better definition of a seizure cluster. But for the most part, I think we learn to talk to our patients about the seizure pattern and give them a clear direction when to use rescue medication. And what are the current rescue medications? This slide lists what's available in the EU and in the US. In the EU, there's a rectal solution other than the rectal gel that we have here, and there's also for diazepam an intranasal spray. So you have 3 different formulations of diazepam, and then the other compound that is used for rescue is midazolam. And in Europe, they had buccal midazolam for quite some time. Here we have the intranasal spray and IM autoinjector. And you see the US indications for that. So that really is the basis for what we are going to talk about for the rest of the evening. And so now I'm going to turn the podium over to John. You go ahead.
Thank you, Cheryl. That was great. Really appreciate your introduction. Their title is a question. It's a fake question. It's not a polling question, because the answer is any seizure is too long. We don't want seizures to occur to begin with, so it's a setup for what we really want to achieve, which is seizure freedom. But the reality is that seizures occur, and seizures occur with different durations, and these durations may reflect the different seizure types. And so when we think about the duration of the seizure, you heard a little bit already about seizure durations according to type, but we can get more granular about this. And this is useful because treatment will depend upon seizure duration when one's thinking about an intervention because the seizure has been too long, going back to the title of this section. And then the point of this is to avoid the consequences of a prolonged seizure or the development of status epilepticus. And so we'll talk a bit about the consequences of failed emergency seizure treatment, something we don't want to occur ever. So let's talk about the durations of different seizure types. Start with a question. What happens in the first seconds to minutes of a seizure? A, enhanced inhibitory GABA A. B, decreased excitatory NMDA receptors. C, decreased excitatory AMPA receptors. D, methylation. Or E, enhanced initial neurotransmitter release. And we're going to talk a bit about these answers in the following slides. So, in the end, what happens in the first seconds or minutes depends upon what type of seizure it is, because the other part of the question that is not so honest is that seizures differ. And so we have here old results, the 20-year-old results, looking at seizure durations from video EEG monitoring. And I'll point your attention to the middle of the slide, which is the median duration by type. These are secondarily generalized tonic-clonic seizures, complex partial seizures, now of course focal seizures, simple partial seizures, also focal seizures, but without impaired awareness or consciousness. Primary generalized tonic-clonic seizures, now generalized tonic-clonic seizures, or tonic seizures. And the median duration spreads out across this patient population, but you can imagine what is typical on the scales in seconds, with the primary generalized tonic-clonic seizures being typically shorter in duration than the secondarily generalized tonic-clonic seizures, or partial seizures to bilateral tonic-clonic convulsion, and tonic-clonic seizures, or tonic seizures being shorter. But then thinking about the clinical situation, and putting your attention to the left side of this slide, it's really the one instance that's relevant, not the median. The median is useful thinking about what to expect typically, but the decision about whether to intervene, rescue medication, depends upon the circumstance. And you can see that the longest duration by type spreads out further. It's a greater spread, and so individuals have a median, but they also have a range. And this is useful information thinking about the intervention of the rescue medication, and ultimately comes down to the situation of whether the caregiver believes from observing many seizures for that individual that that particular seizure is lasting longer than is typical. It's getting to the point of being prolonged. We'll talk more about prolonged in a few minutes. You notice in the bottom right this issue about whether the first or last seizure in a cluster and the durations differ also in there, with an increase in duration as the cluster continues, which may influence the decision about intervention, but also might give us a hint to the detrimental nature of clusters and whether clusters point to another flavor of the prolonged seizure, but through intermittent seizures with a worsening through the cluster. And lastly, for your own curiosity, the difference between awake and asleep focal seizures. This question has been revisited more recently in a larger study, again using video EEG monitoring results. And this analysis, which is really a wonderful paper, that looked at the ranges and give us a more detailed inspection across more seizure types, but also with a sense of confidence intervals. And you can see a blow up of the very brief seizures at maybe a second in duration, seizures where typically we wouldn't think about rescue treatment at all. But also as you scan down toward focal tonic, focal awareness unknown, focal aware, and focal with impaired awareness, you see this increasing distribution in duration, which introduces this problem that we've already discussed as to when is a seizure too long, when is it going to be the outlier, and how we end up needing to have some type of sense for the individual for what is a long seizure for that person compared to what's typical, because the norms end up becoming, or the evidence ends up becoming less meaningful because the groups have a greater distribution. So who's determining the duration? And we know that that is a very difficult thing to ascertain. In practice, we often hear very gross estimates of the seizure duration, and it often reflects what the observer's sense is without knowing an actual time, and the emotional load of being present with someone often close to the observer having a seizure. The study used people close to individuals with epilepsy, but instead of having this report by recollection, the videos of those close family members were shown to the witness, and they were asked about what they saw after they viewed the video. A standard questionnaire was given just to get a sense of how accurate are individuals when recounting moments later after viewing a video of a seizure for the features present. And so it took out the emotional load of being present at the moment, and it structured the responses. The responses included features of the seizure beyond duration, so this is not only a measure of duration, but you can see the accuracy really falls quite quickly across different seizure types. And NEAD, just for clarification, is non-epileptic attack disorder, as was used by the authors of this study. So really thinking more about the first three groups with a sense of a person who's maybe making a decision about the rescue medication also having difficulty in establishing what was the reality separate from what variation may occur for the seizures. And then the inaccuracy may be influenced by, and certainly complicated by, distinguishing between the ictal period and the post-ictal period. So the post-ictal period is the consequence of the seizure. It's an abnormality, but it's not the ongoing seizure. It's the response to the seizure by the brain, and will include, very likely, responses that end up causing suppression and changes to the brain as part of ending the seizure. And so it's one abnormality replacing another abnormality. And post-ictal state can have abnormality of behavior and interaction, and depending upon the seizure type, may not have a clear demarcation, which further complicates the question of how long was that seizure. What we do know is that when the person is post-ictal, rescue medication is not necessary because they're already beginning the recovery. The seizure has ended, assuming there is not going to be another seizure as part of a cluster. It's a separate question. But that's part of the decision making that makes the use of rescue medications a little more tricky in some situations. So let's talk about the treatment need according to seizure duration. Let's start with another question. Why do patients develop benzodiazepine resistance when a seizure lasts too long? A, increased activity of the sodium-potassium ATPase pump. B, upregulation of inhibitory GABA B receptors, C, altered structure and function of the GABA A receptors, D, shift to renal clearance of the benzodiazepine, or E, acute overwhelming glutamate dehydrogenase deficiency. We'll talk about this in a moment. And it's the A receptors, not the B, that are affected by the seizure when it lasts too long, whatever that means. But what it means in this sense is that this is something that occurs as the seizure continues. So let's talk about what happens in the transition from a single seizure to status epilepticus, with the idea that between the two is a prolonged seizure. So the initial milliseconds to seconds, there's protein phosphorylation regarding receptors, there's ion channel opening and closing, which has to do with response to the neurotransmitter, which has been released. Seconds to minutes, there's a change in receptor trafficking. This is where there's decrease in the GABA A receptor. There's increase in the excitatory neurotransmitters, NMDA and AMPA. Minutes to hours, so getting into the period of time and then extending well into it, that is well beyond what we want for any seizure. There's a change in neuropeptide expression, increase in excitatory substance P, and insufficient replacement of inhibitory neuropeptide Y, which of course leads to this issue of the longer the seizure lasts, the less likely it is to stop on its own, because the mechanisms by which the seizure may be altered begin to fail. And then after that, thinking about what is hopefully the recovery period, because hopefully this seizure is not lasting days to weeks, there are further changes, genetic and epigenetic, in response to that seizure. And this goes to the questions of brain change after prolonged seizures and the long-term consequences after the seizure's over from having had an episode of status epilepticus. The question of prolonged seizures is beginning to be addressed separate from status epilepticus, and these are results from a cross-sectional study that was a survey study in which physicians, most of whom were neurologists, were asked to identify patients who had had at least one seizure of at least 2 minutes duration in the prior year. And it was a survey for characterization, so it's hard to call out statistical relations here. But you see in the first panel that prolonged seizures, a person who's had prolonged seizure in the past year is more likely to have a prolonged seizure that progresses to status epilepticus. In other words, is having a prolonged seizure a risk factor for having an even greater prolonged seizure or status epilepticus? And this supports that, although there's not a comparison to individuals without prolonged seizures. It's just a matter of a seizure has to be long before it becomes very prolonged. But these individuals often had seizures that progress to clusters, again, seeing that greater than what you expect. Early ictal events and injuries, meaning changes that are related to that seizure as a whole. And having prolonged seizures have consequences, requiring emergency services, leading to ER admission, ICU admission, hospitalization is part of that. And so it supports what you would expect from common sense that the worse the epilepsy, and by that I mean greater duration of seizures, the greater the risk of consequences from those seizures. So the last section, the consequences of failed treatment, failed emergency treatment for seizures. Question: why are longer seizures less likely to spontaneously terminate? A, rapid depletion of neuronal ATP reserves necessary for sodium-potassium ATPase pump function. B, decreased expression and functional availability of the GABA A receptors. C, increased synthesis and release of inhibitory neurotransmitters like GABA A and glycine. D, reduced efficacy of ionotropic NMDA and AMPA glutamate receptors. And E, accumulation of acidic metabolic byproducts that directly suppress neuronal excitability. The group got it right thinking about the issues of GABA A, decreased expression and functional availability of the GABA A receptor. So we think about the internalization of the GABA A receptors greater with the longer duration of the seizure, but there's also a reconfiguration of that receptor, so the seizure ends up producing a state in which the mechanisms by which seizures may be suppressed are lost, or better word than lost, are compromised. And so this reduction in surface expression of GABA receptors, GABA A, leads to a greater failure of the normal mechanisms, which also ends up compromising how we often approach seizures. In other words, when we think about conventional treatment for status epilepticus, we think about the use of a benzodiazepine early, but we have to recognize that if we don't use it early, we may not have the full benefit of it because of the brain's response to that prolonged seizure. And so the longer the seizure lasts, the greater the consequences. And we think about uncontrolled seizures as being prolonged or frequent, and it's part of that seizure burden. There's more to seizures than just the frequency, it's the duration and severity of the actual episode. And delaying treatment ends up leading to a lesser likelihood of response to treatment. You think about factors in status epilepticus responses, how sooner you intervene and what caused the episode. You can't change what caused the episode of status epilepticus, but you can change your response time. And with status epilepticus, there are changes in the brain, but of course, that brain affects that body and increases the risk for injuries, respiratory complications, other injuries beyond brain-related. And these can include hypoxia, aspiration, arrhythmias, and physical harm, as well as death, thinking separate from neuronal injury and cost. And so I don't think I needed to make the argument any stronger than this. Early intervention for prolonged seizures is warranted, but the decision as to what is the moment to initiate treatment can be difficult for the caregiver, for the witness, for a variety of reasons. So final question. What happens in days to weeks of a seizure? A, genetic and epigenetic changes. B, acute failure of the sodium potassium ATPase pump. C, rapid irreversible internalization of the GABA A receptors. D, complete and permanent cessation of all excitatory neurotransmission. Or E, primary motor cortex atrophy resulting in long-term hemiparesis. Thinking back to a prior slide, I think the clues here is that it's not an irreversible internalization of GABA A receptors. It's a transient and reversible. I'm very happy to hand this over to Dr. Goodall. Please.
Do we know what the betting line is? Is there like online betting that goes on?
Yeah, I think so, yeah.
Okay, great.
I got money on this.
So, good evening, everyone. So, this is kind of a trick question, which I'm really known for writing, by the way. You ask my students. But the answer really depends on, you know, it would be nice if we had very straightforward, very similar formulations with very similar molecules, and we could directly compare molecules. And the problem is, we actually don't have that kind of information, right? So I'm gonna pursue this a little bit deeper. We're gonna talk about some other biomarkers, then I'm gonna try to bring this back together. So again, the clear answer is, well, gee, compare these two, you know, our benzos, our direct head-to-head, or head to rectal, I suppose it could be, and tell me how soon they work in a very controlled, organized manner. We don't have that data. So what we're left with is we need to look at potentially surrogate markers, okay? So there's a variety of answers. Now let me ask the follow-up question. Is the time to peak concentration, the Tmax, is that the same? Is that equivalent? Is that the same thing as saying time of onset? A, yes. B, no. C, not sure. The majority of the group said no. I'm going to agree with you on that answer, but I think also equally a valid answer is, I don't know. We're not sure because of the way the data is. So let's dive into this just a bit deeper, if we could. Okay, so let's first look at what are the general numbers that we're looking at here. Now, we're not going to go through, we don't have time tonight to go through, although I'll show you a little bit of comparative data to go through IV and IM. We did mention that there is an intramuscular autoinjector form of midazolam that's indicated for status, not going to talk about that. There are still people out there using the oral route. We do realize that if we're really looking at trying to get a rescue in, the oral route is really a suboptimal way to do that. These drugs take a long time to get in. There could be variable absorption. So it really should not be considered a true rescue therapy, in my estimation. I don't know what my colleagues think in the modern era. So really we're going to talk about intranasal, then eventually we're going to talk about some other technologies, intranasal, or intrapulmonary, inhaled. So really the answer is, you can see from the slide, for those of you who selected 45 minutes, if you look at some of the other formulations, there are some formulations of diazepam that are out there that, in fact, if you look at Tmax, it's fairly long. So the question is, but does that matter? Okay, let me try to show you some other data to answer that question. Well, first I got to go back in history. Got to go a little bit back in time. You know, this was a classic, almost a landmark study that was done. This is after giving intravenous diazepam and also looking at clonazepam, diphenylhydantoin. For those who are too young to know this, that's phenytoin, dilantin, and phenobarbital. And what was looked at early on was, again, a question now that seems obvious to us, but how quickly does the drug, because ultimately, you know, when we talk about pharmacokinetics, we talk about these parameters, we're talking about plasma. That is, in my estimation, the wrong compartment for us to be looking at for an acute treatment. Really, I sometimes don't care what's in the plasma. What I really care about is what's getting in the brain. And in fact, if you look at this slide from the 1980s and looking at diazepam, for example, that if the vertical axis is the brain to blood concentration, that in fact you get rapid distribution. So one of the hallmark features of benzodiazepines is that these drugs are rapidly taken up by really any route of administration. They are rapidly transmitted because they're lipophilic molecules into the brain compartment. Okay? So the drugs get in. The question is, getting it in, does route matter? But we know these drugs get in fast, and time is important to us. All right, so if I said the gold standard, comparing all the, you know, say the intranasal treatments together, and could say definitively, you know, here's what the answer is. But as we know, and if you've looked at this literature, the studies looking in intranasal diazepam and intranasal midazolam had a little bit different study designs. They had different outcome markers, you know, versus, you know, timing the exact time or versus an epoch of time of which seizure termination. So that's one a variable that's in there. I think John correctly identified and brought home the point too, that if we look at the, you know, who's our data acquisition, who's doing that? These are caregivers, loved ones, parents, whoever, that now they've got a loved one that's having a seizure, having to get that drug administered and having to have the wherewithal, even though they've been trained, to say, okay, I'm now starting the stopwatch. So we can see that there's variable data that's there. So let me ask this question. So apart from seizure termination, how can we assess? What other markers do we have to assess time of onset of rescue therapy? A, EEG biomarkers. B, onset of CNS adverse effects. C, again, time to peak plasma concentration. Or D, all of the above. Okay, because I'm going to talk about EEG biomarkers as one surrogate mechanism from a neurophysiologic approach, and I would love for my colleagues up here who do this for a living, you know, to weigh in on this. Onset of CNS adverse effects is something which I think is legitimate to discuss. We still have that time to peak concentration. There are those that will still argue it's that peak plasma concentration, and that is a completely valid answer. And then there's all of the above. All of them potentially have a role. Okay, so let me start talking about pharmacodynamics with you a little bit, because that's really what we're talking about, right? We're talking about when the onset of effect. This is some data from a few years ago, excuse me, of looking at concentrations. Again, this is of diazepam. This is, again, actually being given intravenously, not intranasal. And one thing that I want you to see here, that I told you the diazepam, all these benzodiazepines are rapidly taken up by the brain. They rapidly cross over the blood-brain barrier. And that tends to be equivalent to the unbound concentration of these drugs. So that part follows classical pharmacokinetics. And you can look at this, but so we know that, it's getting in quick, but what else can we look at here? This particular set of investigators also looked at EEG. They looked at predominantly EEG, sort of a total power in that beta spectrum, which as beta spectrum has been linked to benzodiazepine effects. It probably is reflecting GABAergic activation, which we've already talked about, that is important. So they looked at change in not only getting the drug in, but if you look at the change in EEG effects, there was, again, a very almost superimposable time curve. You get fairly rapid effects. But I think equally important, this was actually a group of anesthesia folks that were looking at it, time to sedation, time to lack of verbal responsiveness in these individuals. And again, you can see the time here was pretty rapid. Okay, so this tells us that there's a fairly good rapid uptake, but it's not just, we have other markers other than necessarily seizures that I think we should be considering. Okay. Let me shift over to midazolam for a moment. This is some data that we actually published a number of years ago now. This was a group in healthy volunteers where we compared the old formulations of intranasal midazolam that used to be compounded versus what now is the brand name product of midazolam nasal solution as well as IV. You can see the doses here. And what we found, that's why I told you before, it was a little bit of a trick question asking you about Tmax. We look at midazolam is given even intranasally. If you look at this graph curve here, again, we're comparing intravenous, which is in the open square, versus the green colored box and circle, the different doses. The green stuff is that intranasal formulation. You see what turns out to be almost superimposable curves. So again, midazolam is actually has rapid distribution whether I give it IV or we give it intranasal. I will not talk about it tonight, but I think the other thing that we frequently forget when we talk about midazolam is the metabolite. The 1-hydroxymidazolam also has activity and probably is contributing in some fashion, don't know exactly how much, to anti-seizure effects. So let's talk about those other things. I showed you a little bit of EEG and a little bit of side effect data for diazepam. Let me shift and talk a little bit about, tell you what I know about midazolam. Again, this is a study we did. Please bear in mind, these are not patients with epilepsy. These are healthy volunteers. But in some respect, that gave us a reproducible way to look at this. We looked at sleep onset, Stanford sleepiness. We looked at some other measures of arousability and awareness. And if you look at this, the higher scores, just to orient you to these graphs, higher scores means greater sedative effect on both these different scales. And once again, if you look at this, now look at the time profile. And this is what I want to draw your attention to. I just told you that Tmax for midazolam in this same pharmacokinetic study, around 10 to 15 minutes, somewhere in that range. If you look at the onset of these CNS effects, you begin to see things really rapidly within a couple minutes. And 2 minutes was really, if we were looking at windows of opportunity, if you will, that's really what we're really looking at. How quickly can we achieve some effect? Now again, this isn't seizure termination, but it tells me the drug is getting into the brain and doing something. Okay, let me show you another bit of evidence. See what, again, I want to know what my colleagues think here about my interpretation and use of EEG. This was actually a fascinating study done a number of years ago, looking at, again, quantitative EEG. And what these investigators did was they either gave intranasal midazolam at 3 or 6 milligrams. This was also a compounded formulation of midazolam, not what's commercially marketed now. So if anything, the compounded version has greater variability in bioavailability than what we have now, versus 5 milligrams of IV IV midazolam. You can see the concentration time curves. Again, Stuff gets in pretty quick. But I think what's really fascinating here is if you look at the EEG. Now, the top graphic is the absolute power, so they included the entire beta spectrum as well as, I think, sigma and some other things, so they lumped it all together for graphing purposes. But what you can see here is, in fact, again, a fairly quick onset of, at least in that beta range, indicating a GABA effect, a benzodiazepine effect. In the slide, and the actual data table there, you get actual numbers. And again, this was a study looking at time to unresponsiveness, lack of verbal responsiveness or arousal. That was the outcome measure. This was not patients with epilepsy. These were subjects. But again, if you looked to the time to that maximal EEG effect, we're really talking about minutes, 5 minutes on average. And there appeared to be a dose relation. So again, 3 minutes, a touch longer than at 5 minutes. And again, that unresponsiveness certainly in under 10. But if I look at these biomarkers that are out there of other CNS effects as well as EEG, I think there's compelling evidence that these drugs do, in fact, are affecting some neurophysiologic change early. So let's move on to the other topic here, the impact of a route on time of onset and seizure control. That's really kind of saying the same thing. But here I have a quiz question for you. So we're going to finish off with this tonight. Please order, my students hate it when I ask these kind of questions. Please order the following routes of administration of rescue treatments by their typical time of onset of effect, from slowest to fastest. Again, so this is some respect, going back to that old slide, but perception. So A is, again, we're going from slow to fast. IM to buccal into IV. Answer B, rectal, buccal to IV, so just slightly changed. C, and then D. Good luck with that one. Is Dr. Pina Garza says, IV is always going to be fast, but if we really truly look at the routes, and IM is a very useful route, again, in some pre-hospital models of status epilepticus, but again, that's not what we're talking about. We're not talking about status and emergent treatment. We're talking, rescue treatment for clusters or acute repetitive seizures or maybe prolonged seizures that we're going to be talking about. Really, that intranasal route really truly gives us a reliably faster route of action, onset of action.
So you're not going to tell them the right answer?
I just did. Intranasal. Intranasal. We're going to go, well, IV is always going to be the fastest. Okay. So this is a meta-analysis. This is how I'm going to finish up. This is a meta-analysis of trying to justify my answers there, of looking at a group, and this is, again, this goes back to 2015. We now actually have more studies of this, of looking at what our gold standard treatment would be in terms of speed. Clearly, it's always going to be IV, then looking at IM, and then we look at those intranasal, midazolam, as well as the buccal. These are the things, and rectal. If we look at it, we're all within that time range of those therapies that are within this window that Dr. Stern talked about, if we're really looking to hopefully prevent something going from a prolonged seizure and preventing these other disastrous clinical outcomes. So I think we know this. This is where we're going to start leading into the next discussion. We clearly know there's no perfect therapy out there. There's disadvantages to everything. We have problems with some of the routes of administration. They're slow to administer, for example. If we think about rectal, there may be, while absorption can be fast, but if we look at the duration of time it may take to actually get the drug administered to a patient, we're losing that valuable time. Setting up an IV certainly may not be practical, and that may lead to a prolonged time. Again, we need to be able to reach at active dose or a pharmacologically meaningful dose quickly. We have those technologies now with intranasal formulations. We can administer in that nasal cavity these doses which have been shown to be effective. We do know that challenges, can we stop the recurrent seizures? We do know that that's another consideration that we haven't necessarily directly addressed. We're not only concerned about stopping that first seizure, but stopping the ones that come after that. And then, do we have a drug that's safe to give in the home setting? And I was really pleased in the first quiz question asking about was a perceived barrier, was that respiratory depression? And I'm really glad that very few people answered that question. That should not be a barrier to having any of our patients take these medicines. All right, you have one more round to go, and with that, I'm going to turn this over to my good friend, Dr. Pina Garza.
Thank you.
And for everybody that is voting, you have an opportunity to win. The end line is just visible.
Vote early, vote often.
So the round 3 is something that we've been working on, trying to make things better. I still remember 25 years ago when we started saying, you don't have to wait 30 minutes, you should try on 5. Believe it or not, sometimes people waited 30 minutes to stop the seizure emergency. Crazy. So back then, we didn't have a lot of database to say 5 minutes, but I had the gut feeling 5 minutes was good, and I started sharing, and others accepted, and we took off with 5 minutes. Now, looking at all the data that we have reviewed and other, we were able to get actually a team to look at the data and say, when should we intervene? Just imagine that for the first 5 minutes, I put someone convulsing in the background that you love. And say, at the end of the 5 minutes, I'll do something. It's crazy. So, we're going to advance, if I can. All right. So I'll talk about defining the REST concept, which is a concept. It's the rapid early seizure termination, the aims and the goals of these, and the REST treatments in clinical development. Defining the REST. We'll start with a little question. This is the time that you can take over, the rest assured. Massive. So what are some of the negative effects of a prolonged seizure? Massive depolarization of neurons with glutamate release that may trigger a cascade of changes leading to neuronal loss. Altered synaptogenesis of a network due to neuronal loss. Decreased brain oxygenation leading to neuronal injury, or all of the above. So why did we start the seizure termination project? Because there was a big gap in seizure emergency management. When I talk with my colleagues, whether through academic in our institution or a CME program, when we talk about prolonged seizures, prolonged mean a ton of different things for the audience. So if you don't have a definition, it's very hard to target it. But for some people, even for patients now, the most common definition other than 5 minutes, which actually came from us saying 5 minutes is too long, 1/3 of patients feel that more than 5 minutes is too long. But the majority say prolonged seizure is longer than the previous ones, which is bad if all the previous ones are 15 minutes. That's waiting a long time for every patient. So we tried to standardize that definition, have a consensus guidelines. It could not just be from one person reviewing that. So we got a very good group to look at this, and then try to use what we have available in a better way, and try to have that concept to develop new options. So this is not for just one single goal, but we're trying to address this need for patients with epilepsy. So if you look at the causes of mortality, which again, we lose more patients to epilepsy than to breast cancer. We just don't have as much awareness as we should. Both very important diseases, and we have to try to prevent that. But there are at least 3 things that are clearly connected to the duration of the seizure, whether it's a cluster, status, prolonged, or SUDEP, which by the way, I think is SUDEP should not be sudden unexpected, but sudden unpredictable. It's expected. That's why we talk about it. And when we get these, we decided to get some expert from Europe, some from the United States, get all together, try to scratch our heads, and go through a Delphi exercise where we presented different questions and we were able to answer anonymously through an electronic system to see if we were in agreement or not. And we felt that if more than 75% of us felt strongly or agree with the statement, that would be consensus. It's very hard to get 100% when we get us all in the same room.
Never.
So again, there are ways to look at the data, and now more than your gut feeling that back then 25 years told me 5 minutes is better than 30. If you look at seizures, and it was presented very elegantly by John, most of the seizures self-terminate or lack the property to self-propagate in a certain period of time. And when we look at the generalized tonic-clonic seizures, most of the time that's in the first 2 minutes. So it's rare for a generalized tonic-clonic seizure to go beyond that time. When you look at the focal seizures with unawareness, 5 minutes is the time. It doesn't mean that that's a safe time. This is actually the next, if we move from 5 to 2 minutes, we're moving in the right direction, but we're not done. It's just a one good step, because remember that we have a lot of evidence that prolonged seizures, like a status epilepticus, injures the brain. And non-seizures, done. But prolonged seizures is in between. It's the continuum. And that's our job, if we want to have more evidence. Clinically, we have all the potential benefits of preventing the consequences of a long seizure. But also, in the long term, we have a constant factor that keeps hitting that brain and eventually may affect the cognition or anatomically having a thinning of the cortex or others. And there's a lot of research in that area. So the rest, aims, and goals. What is one of the primary goals of REST for treating seizure emergencies? A, identify optimal time to intervene to rapidly terminate the seizure. B, only reach consensus about managing seizure emergencies. C, replace the need for all hospital care. Or D, develop better options for long-term seizure prevention. So yes, we are trying to identify a better time to intervene. So the rest aims were different. To me, any seizure is an emergency. We started saying, like, let's talk about seizures and let's talk about seizure emergencies. Any seizure, especially if I still remember my mom when I had a feral seizure. 30 years later, she told me exactly the day that happened, the hour, and a great historian. And then I asked her again because I wanted to confirm that it was valid information. It was. And I saw her pupils big and tachycardia. This is like post-traumatic stress disorder. That's what people feel when their loved ones are having a seizure. And unfortunately, many times they desensitize with having a chronic epilepsy that keeps hitting them over and over. But it's an emergency. And then there's the emergency that we want to stop to becoming a larger emergency. So we want to stop prolonged seizures. We want to stop cluster seizures. We want to stop status epilepticus. We want to stop the disability of having to go to the emergency room or being hospitalized or worse, being in the intensive care. If you just breathe the air of the emergency room, it's 3,000, and then you stop adding for anything else that you have to do. So even the cost of that, and more important, trying to prevent death in these patients. People die from this. So when to intervene? What would be the best time? And looking at surveys from families, they tell you a minute is too long. And they may be right. Even for preventing neurologic sequela, that's our point, to try to acquire more data. They may be right. I'll tell you what my dream abortive treatment will be at the end, and I think it's possible. And identify the ideal seizure termination medication. So we have good things that we can use, and if we don't have the ideal, it's not an excuse to not use what we have in a better way. So if we have medications that take longer to be efficient or effective, we have to use them earlier. Regardless of the Tmax, right? It's the time of action what matters, like Barry presented. So the goals, again, the consensus guidelines, we wanted to define prolonged seizures. Cluster seizures, which to me, the best definition is double or triple your baseline frequency, whatever that is. There are people that, if you just want to say having 2 or 3 seizures, they live in a cluster. So every day is a cluster. So when they go to double or triple, that depends on the scenario. Every definition has to be at the end individualized for your patient. So another goal was improve outcomes, to have better survival, better neurological outcomes, less need to be in the ambulance care. If you think about it, it doesn't only affect epilepsy. We tell every epileptic to call 911 for every seizure. Some other people are going to die from cardiac problems, right, or a stroke. We would just disable the ambulance system. So they have to go home with a better plan than calling 911. And then the concept of rest is really a concept for rapid early seizure termination. It's easy to remember. Put the seizure to rest. And acute cluster treatment, to act. If you know these patients have cluster, you don't have to wait. You're treating the next seizure. You give the treatment as soon as you can, and you can stop the one that is happening and the one that is coming. That's if the patient have a reproducible pattern of clusters. And then to develop better options. We don't have yet the ideal option. It would be so nice, and it's possible, why not? If we have just like insulin pumps, we have machines that are implanted that detect certain motion and deliver a little shot of benzodiazepine immediately. That's the future, probably. But in between that and where we are, we have options that are being studied that are important. So again, on the goals, terminate ongoing seizure activity, ideally in less than 2 minutes, and prevent evolution into status epilepticus, minimize post-ictal time. Sometimes there are people that have short seizures. That's why it's so important to individualize. Some people tell you now, every time that I have an aura, the aura lasts like a minute, but every single time I have a status epilepticus. You don't wait for the status, you treat it based on their history. Every time that I have seizures, it's a cluster. You treat them as soon as the seizure starts. Now, when you have people that says only 10% of the time that happens, then you have to individualize. When do we do it to not overdo it? And the only reason for overdoing is just the limit amount of treatments that you may have.
What you said a couple of slides ago, some people live with multiple seizures a day. So how do you define a cluster? But I think to my clinic, even in that scenario, the families and caregivers still can recognize this is a bad day, right? They come in and they say, oh, he had a, yes, of course, patient has 3 seizures a day, but this was a bad day.
Yes,
fully agree. Fully agree, right? So I think that whether we have an actual definition or not, they know.
There's bad days.
They know.
Yeah. Bad days, sometimes the reason to intervene.
Yep.
But sometimes it may be the post-ictal period too. There are people that have, if you can change that post-ictal by aborting the situation, that's valuable. So there's a lot of different situations where aborting the seizure is of a lot of value. It's just great for someone to have something to do other than nothing. That's what happened when migraines, when we first started having triptans. For a person with migraines, I'm going to say a woman because it's more common. 90% of adult women. In kids, it's 50-50. But just having that with them gives them some independence. So I have a lot of patients. I have one that sent me selfies from Knoxville when he goes to the UT games. And he had used it one time there and stopped the aura and watched the game, and the Vols won. And he sent me a selfie. Hey, thanks for the rescue. So and really the most important, I'm a believer that prolonged seizures cause some degree of injury, and I think that's the next step, try to prove, you know, what's the threshold to start seeing those changes, because they occur, you know. Definitely, if you look at your patients with refractory epilepsy over time, sometimes it may be part of the epilepsy etiology, but many times it's the result of the seizures. So what is REST? Again, rapid early seizure termination. We feel that once the seizure proves to be too long, we should not give it an opportunity to become a bigger crisis. And ACT, again, for clusters, the time is right then. If there's a patient that, you know, about 85% of the patients that were randomized to cluster trials have clusters. That's what we saw with the placebo. So you can prevent the situation if you treat them ASAP. So to whom, you know, we came with things is too obvious. Like if you spend your life in the ER, in the hospital, that's clearly a need. If you have a status epilepticus, you have to be very active on trying to keep these patients. If you have prolonged seizures, you have to give them the opportunity to stop the crisis. I'm going to share with you that in my, I have a couple of my trainees here, and we give a seizure plan to almost everybody, and we give a rescue medication to almost everybody. I think for 60% of my patients, they never use it, but it's like a great fire extinguisher. If you don't use it, just be happy. But when you need it and you don't have it, then you may end with a bad situation. And obviously for the people that have the typical situations that need it, that's more important. But I don't remember the last time I had a patient in the IC unit with the status epilepticus, and very few come to the ER. So it makes a huge difference, but you have to have a very organized plan. Yeah. And really, if you think about it, what would I do if this was my kid? You would have it. So I'm going to ask you another question. What would you consider to be the window of opportunity to prevent a seizure emergency? The aura, within first 2 minutes, within first 5 minutes, or within the first 10 minutes? So in this case, you're going to be right with many of the options. And clearly, for many patients, the aura stage is a great opportunity. There are people that tell you they start having myoclonus, and that always evolves into a convulsion. You have a chance to stop it. People that have different auras will often evolve into prolonged seizures or status or disability. That's a great opportunity. Still within 5 minutes is not bad, but the longer you stretch it, the less ideal that treatment is. When should rest be administered? As early as possible. As early as you can recognize that this is something that will be prolonged, if there's that capability. And a lot of patients actually tell you. When we did some surveys on patients, you know, about 40% of them had auras, and about 80% of them, they felt that it was like very accurate, that when they felt the aura, they were correct, and it often evolved into a prolonged seizure. And so I think in those situations, we have to intervene as soon as possible. When it's obvious, when you have a generalized convulsion for 2 minutes, I think it's definitely to intervene. There are factors. Someone asked me, what if it happens during the night? There's a lot of nocturnal seizures. Well, you have to add the component of saying, you know, this has started longer than I have watched because we were all sleeping. So maybe the 2 minutes become less than that. So there's a lot of different things. For clusters, I think once you identified what the cluster is, and for many of our patients that have single seizures, when they have two, it's a cluster.
Right, exactly.
And for people that have cluster every time, the next one you can say is 80% chance of being a cluster, you have to treat each one like if it was a cluster. And for people that have daily seizures, which unfortunately that's still the case, we still have to address that. So important features of an outpatient rest medication: rapid onset of effect, ability to terminate an ongoing seizure, ease of administration, this has been mentioned already. Time is very important for convulsive seizures. Try to stop them if they last more than 2 minutes. The statistics, based on what we know, shows that that's likely to become a status. Focal seizures, when it lasts more than 5. That time between 5 and when it's clearly status, 10 minutes. Absent seizures is less of a critical seizure situation regarding the metabolism in the brain and the injury, but it's not harmless. You know, these are people, everybody tells us, I don't want to be a zombie. This is what makes you be like a zombie. You can be walking around and unprotected and walking the street. So absent seizures after 2 minutes is unusual, and it's a time that you can intervene before it goes to 10 minutes. Seizure clusters, we already talked a little bit about it. So again, the rest treatment is the opportunity to intervene before it's obvious status epilepticus. It used to be 30 minutes, now it's 5, but there is a window of opportunity before that where the GABA receptors are saying, I'm here, throw me the ball. And then when you throw the ball late, there's no receiver. How is that for a football weekend?
Seems appropriate.
All right. And the treatments on clinical development, which of the following is a rest treatment in clinical development, if you know? Rectal diazepam gel, intranasal midazolam spray, inhaled aprazolam, intravenous lorazepam injection, or sublingual clonazepam tablet. So it's like a lot of things that are giving sublingual, they're still GI absorbed. So it gives you a false sense of security that they're going to be absorbed, but it's a long Tmax or T of action. So the inhaled aprazolam is something that is in development that can give us a great opportunity to intervene fast. It meets the needs of patients, which said, I want something that works within a minute. So the time to effect is about 30 seconds. It just requires a mild inhalation. It's not like an asthma inhaler. And there is also the midazolam needle-free transdermal, which is another option that may act in a short time as 3.3 minutes. These are not available yet, but that's what's coming in the pipeline. And we shouldn't stop there. We should try to pursue better treatments when these become available. But more important, we should use what is available now better. So when you look at the concentration of midazolam with the needle-free autoinjector, it's pretty good, as you can see. You have the two treatments here, and they're almost equally showing in the curve. When you look at aprazolam, you look at the placebo group. So some of the patients self-terminate the seizure because that's the nature of seizures. Not everybody is going to have a prolonged seizure every time. But the percentage of patients with aprazolam pulmonary inhalation or absorption is in the 65%, whether you use 1 milligram or 2. Again, the difference in the time to seizure cessation, which is faster again when you are able to use the aprazolam compared to placebo. And then it also has an effect that you would expect to be shorter for clusters because it's not a very long half-life, but more effective for aborting seizures. So the inhaled aprazolam for rest, safety, 65.8% of the treated patients were responder. It was very well tolerated. The most common side effects are cough, somnolence, and dysgeusia or abnormal taste. I always think that if you're able to complain about the taste after a seizure is great. And intensity of adverse events, mild or moderate, so not any serious adverse events. definitions matter, so it's very important to know if you want to follow something, you're going to shoot something, you better know what the target is. So it's very important to know what the prolonged seizure is, what the cluster, which at least the concept should be there based on what we know. And we know status epilepticus. And you know, just like it was 30 minutes and it became 5, I think with time, that's my prediction. I hope I'm still alive, but it's going to be less. Because there's definitely, seizures are not harmless. Time is brain, just like with the stroke. So undertreated seizure emergencies lead to more risky situations, neuronal damage. And the goal is to be able to speed up the process to abort the seizure. So I encourage you, every patient with epilepsy should have a seizure action plan. And not only that, tell them to go home and do a seizure drill. The best things we have for preventing things is the fire drills.
That's true.
And they don't give the students a list of things of what to do, like we do. They tell them, go home and practice, or we do it in the school. So the only way that you can be efficient about the stopping seizures like that is to have the family involved, just like the nurses do. We go to their schools and we tell them how to do it, and we do like a seizure drill.
Do you have, I have in the office the, the models for the intranasals,
Yep.
so we have them try that before they go home, just to show the...
As simple as that. I still remember one mom back where she called me in the middle of a seizure. She told me, I cannot open the container. So I included that into I said, just open it and close it again, look at that, handle it. It's not gonna self-discharge. So all those things are very important. It's very easy when we tell them because we're familiar with that, but they're not. So try to do work in that area as much as possible.
Thank you so much for spending your evening. It's been a long day, and you spent your evening with us, and so we really appreciate you, and enjoy the rest of the conference.